Thank you, Sages, for this great opportunity. It's an honor to have this podium. My topic's going to be on the bariatric surgery and safety in elderly population, specifically age greater than 65. I have nothing to disclose. The background of our study is published in 2006, and it's sort of a conventional thought that patients who are greater than 65 were considered a high morbidity and complication rate associated with operation. The recommendation, early part of the bariatric era is to limit the bariatric procedures available for elderly patients. There's expected increased number of candidates for bariatric bariatric procedures in the elderly population as the life expectancy is increasing, and then improvement of medical care in general. There's been many publications in the last 10 years for the safety of bariatric procedures in geriatric population, but data is still scarce, and we'll go over that in a little bit. The aim of our study is to report our outcomes in bariatric surgery in patients age greater than 65 at our institution. As you can see, this is sort of the meta-analysis that was published last year that goes over all the elderly patient, quote unquote, but as you can see, there are not that many data out there available to us that's specifically looking at age greater than 65. And the biggest sample size, as you can see, is less than 200. And there's been really coherent data out there available to us whether or not it's really safe to offer them bariatric procedures. This is a retrospective review of all bariatric cases 65 years and older. It's from 2005 to 2015. That's 11 years of data that we collected. And we compared to a control group of last 5 years under 65 from 2011 to 2015. The outcomes that we measured were demographics, comorbidities, and surgical complications. This is our results. As far as the demographics, as you can see, the BMI, there was no differences. However, you could see that the male representation in the older group had higher, at 42% as opposed to 30%. That had a statistical significance. And as you can see, the ratio, the distribution had a statistical significant differences as more Caucasian population represented over 65. And you can see that more African American population were represented in the younger group. The comorbidities of those two groups were, we suspect, the elderly group had more comorbidities, especially hypertension, sleep apnea, and hypercholesterol. There was no difference between, in our study, diabetes and depression, and gastroesophageal reflux disease were more prevalent in the younger group. This is sort of to give you the overview of our experiences in the last 15 years. As you can see, there's a big surge in bypass in the beginning, and there's more band that were placed in the beginning of the 2000 and 2005. And as you can see, the number of bypasses are steadily declining as the sleeve number comes up, and then the revision number is also going up as the band number is going down. This is sort of important to know because when we first looked at the case distribution, and there was a statistical difference in the what type of procedures each group had, as you can see, there's more patients age greater than 65 had more band placed, less sleeve, more bypasses, but then interesting, the revision was less. And but when we matched the time period, as you can see that this is a little bit more expected data in the sense that there's no band, but more sleeve, and now obviously increasing revision surgery as the primary index procedure as they get older, and then the failure of weight loss or the complication that arise from the previous bariatric surgery, probably patients getting more revision surgery. The outcome that we measured, the readmission rate, which was any ER visit after the discharge, As you can see, there was a statistical difference, and patients were being readmitted at a higher rate when patients younger. And length of stay was statistically different also, and it was a day longer for the elderly patients. These are some of the complications that we measured. As you can see, there's no statistical difference in between those two groups, including wound infection, obstruction, strictures, leak, bleed, fistula, ulcer, nausea, vomiting. And the only difference that we saw was the reflux rate when patient had a higher, the older patient was found to have a higher rate of reflux at 8% as opposed to 5% in the younger group. But the other measured parameters had shown no statistical difference. So our conclusion after reviewing this data is that bariatric surgery can be safely performed without additional short-term postoperative complication in patients older than 65. Older patients should be well informed prior to surgery for possible increased length of stay, but without significant increased postoperative complications. Age greater than 65 should not be used as a contraindication in bariatric surgery. Thank you very much.